very important aspect on public health. I consider that it needs an emerging strategy for suppress the challenge induced by antimicrobial resistance. And yes, and we shall start with the first presentation of Dr. Valeria Hertea, primary care physician, family medicine, and member of main association for pediatric education in family medicine, and founding of member of RBMF. So, shall we start?
We have a video presentation.
Să transmitem informația către populație și către colegii noștri, educația pentru sănătate, dar educația pentru sănătate văzută ca diplomație medicală, pentru că până la urmă între știință și dezinformare va câștiga aceasta. Ce este important? Undeva la începutul secolului 21, lucrurile au început să se schimbe și populația globului, pe lângă faptul că a crescut numeric, sigur, a întâmpinat și foarte multe provocări. Despre secolul 21 Adrema spunea că va fi unul religios, sigur, că și asta a fost pusă a fost controversat între a fi celebră și urmărește pe fiecare dintre cei care trăim în secolul 21, să nu uităm că despre ceea ce a spus Malraux s-a discutat atât ca un testimonial că ar fi aparținut lui, cât și că ar fi fost o parafrază a unui alt autor. De ce este important? Pentru că, practic, este vorba despre încredere, despre faptul că putem modela lumea dacă ceea ce manifestăm este altfel și dacă ceea ce transmitem este adevărat. Discuția, de fapt, în această prezentare va fi despre ceea ce este fals, despre ceea ce este adevărat și despre rolul pe care îl pot juca antibioticele pe care le putem utiliza în efecte adverse și mai ales pe copii. Haideți să vedem, în primul rând, cu ce ne confruntăm în secolul 21, cu abundența informațiilor. Am pornit la anii 2020, anii de pandemie și practic lumea s-a divizat într-o lume prepandemică, pandemică și post-pandemică. De ce este important acest topic? Pentru că, în primul și în primul rând, explozia informațională a influențat lumea. Nimic nu mai este ca înainte. Transmitem informații. Din păcate, ele pot influența gândirea, acțiunea, modalitatea de a implementa în practică aceste informații. Și dintr-o dată ne-am trezit că în afară de pandemie ne confruntăm cu infodemie. Iar faptul că informațiile nu întotdeauna sunt corecte reprezintă un real pericol. Haideți să vedem ce s-a întâmplat la nivelul istoriei sociale a globului. În 2019, în ianuarie, la Forumul Mondial Global, s-a discutat despre câteva probleme care sunt fundamentale. De exemplu, poluare, boli non-comunicabile, hipertensiune, diabet, cancer, despre influența, despre practic, s-a discutat că va urma să vorbească. Unde și când și cât de severă va fi fost o problemă. Ca și când ar fi fost o avertizare. Nu în ultimul rând despre populație fragilă, despre rezistența antimicrobiană și despre dezvoltarea paraziți, bacterii, virus, fungi, rezistente la orice fel de medicație. Discutăm de rezistența pandemie, tuberculoză, a multor alte boli. Ebola e o mare provocare, sistemele medicale slăbite, ezitanța la vaccinare care este o mare provocare, de asemenea bolile de dengue, HIV, reprezentau a urmat pandemia, pe care o știm, și sigur ne-am confruntat cu discuția dintre acceptanță și ezitanță, dar nu doar la nivel de vaccinații, la nivelul tuturor problemelor de sănătate. 2010 reprezentau probleme de sănătate. În 2021, Harvard publică o carte, Plăci deasupra undă. Cum au schimbat bolile cursul istoriei. Și știm clar din această lucrare, și nu numai din această istorie a umanității, că de fapt fiecare conflict a fost însoțit de toate, fiecare evoluție, perioadă de evoluție a umanității a fost însoțită de modificări care țineau până la urmă bolilor. Bolile infecțioase, conflictele armate, au produs astfel de conflicte. Iată ce se întâmplă mai departe. 2025, același forum mondial, vine și prezintă prognoza pe 10 ani și respectiv pe 10. Lucrurile se schimbă în afară de dezinformare, de misinformare, apar peste 10 ani provocări care țin de biodiversitate, de schimbări ale sistemului. Toate bune și frumoase, dar ne confruntăm din nou cu fake news, ne confruntăm cu schimbări climatice, conflicte armate și nu în ultimul rând uz și abuz de educație. Să dăm un exemplu. În țara la noi a apărut ceea ce se numește un fel de administrare americană din extrem de importantă această perioadă pentru că modelează atât sănătatea mamei cât și sănătatea copilului alimentat la sân, sănătatea copilului dacă vorbim de Există medicație care poate fi utilizată fără riscuri și medicație care se utilizează cu riscuri. Te spun documentele științifice, foarte multe date pe care le înțelegem în profesioniști de sănătate și care ne aduc în față de fapt lucruri pe care noi le înțelegem ușor, dar pe care le înțelegem de date, pentru că noi nu toate le acordăm suficiente pe transmit informația. De foarte multe ori, bunăvoința și faptul că ne dorim să transmită cât mai corect niște lucruri, ajunge în spațiu public prezentat în termeni tehnici. Acești termeni tehnici nu apar diverse campanii publicitare. Se folosesc ele. În primul rând, accesul către populație se face utilizându-se termeni simpli. Termenii tehnici sunt lăsați în parte. Pacientul înțelege mult mai repede explicația unui specialist. În rest, se folosesc motoare de căutare pe care le în timp există și riscul transmiterii de informații defectuoase. Există, sigur, și revenind la medicația care se poate utiliza sau sarcinii, există lucruri în care scrie clar, nu le folosim. Un exemplu, produse din sarcinelor, nu în ultimul rând, medicamente strict interzise. Cunoaștem cu toții care determină focul și prevenție nu se utilizează. Mesajele foarte clare ajung la populație. Ce se întâmplă însă dacă mesajele nu sunt corecte, dacă există dezinformare, volită dezinformare prin lipsa de cunoaștere profundă. Nu în ultimul rând, misinformare personală. Spune-mi de fapt că ar fi cea care influențează masele modele de definire. Lucrurile devin mult mai serioase și mult mai grave. Haideți să vedem ce s-a întâmplat practic. Și abuzul. Păcate avem și conflicte armate. Și atunci, revăzând lecția istoriei, ce putem spune? Că practic nu mai răspunde. De asta a constituit s-a constituit o parte sănătății acolo. Niceful s-a constituit. Ce putem să spunem? Că niciodată istorii nu au văzut atât de repede să transmitem informația pe limba lumii. Și asta să spunem că a fost de altă parte, nici nu am văzut atât de atenție atât de mare atenție false. Dar în același timp am dorit să prin aceste informații populația noastră. Și totuși știința s-a confruntat cu ceea ce se numește mirafaltă. Avem sau nu medicale, sau nu de transmitere. Lucrurile esențiale de sănătatea umană, cum putem să modelăm cunoștințele de care de la oameni tot pe calea diplomației medicale. Avem nevoie mai mult ca oricând să pledăm pentru educație. Avem? De ce? Spunem noi pentru personalul medical, de ce importanță de pregătiți pe diplomație medicală? În primul rând, pentru că pot schimba comportamentul populației, dacă populația cu ceea ce noi numim evidence-based medicine, informații cu bază științifică, transformate și transmise într-un limbaj comun, arătând respect și compasiune pentru suferința omului, fiind eficient, discreți și mai ales îndurători în situații de genul celui care a fost respectând un cod determinat. Nu în ultimul rând, asumându-o. Pentru noi este esențial să știm câteva lucruri care, în condițiile în care vorbim, de exemplu, despre uzul și abuzul de antibiotice, rămân esențiale. Populația are nevoie să știe câteva informații foarte clare. De ce ați utilizat antibiotice? Mai ales dacă am o parte. Cum să utilizezi antibiotice? Sfat medical, de să-l utilizezi, cât să-l utilizezi, cum să-l utilizezi, care ar fi doza pe kilogram, foarte important pentru a evita influența renală, influența hepatică, taxul sau da. Cât timp să utilizezi ca să obțin efectele judicioase pe care le doresc. Am sau nu am nevoie de prescripție, de ce este important? Toate lucrurile acestea au nevoie să fie transmise într-o campanie permanentă de educație a populației. Dar ține de comunicare și nu în ultimul rând ține de ceea ce noi putem transmite bazat pe știință. Pentru că numai utilizând știință tradusă în termeni clar, simpli, transparenți, corecți pentru a înțelege fiecare om despre ce vorbim, de-abia atunci vom putea obține și rezultate. De ce pledez pentru diplomație medicală? Pentru că, până la urmă, acest status al medicului permite, practic, rezolvarea frontierelor, permite, practic, transmiterea informațiilor în așa fel încât toată lumea să înțeleagă că fără sănătate nu poți să ai nici progres, nu poți să ai nici dezvoltare, iar istoria umanității, care registrează conflicte armate, din păcate, să ne dezvoltăm. Dacă informația ce vorbește. Educația medicală pentru sănătate sunt prevenție de sănătate. Și nu în ultimul rând schimbare. De asta ține de fiecare dintre noi. Cred că fiecare, indiferent dacă are nevoie de a dezvolta balanța informativă. Astăzi, tocmai pentru a putea încrederea dar mai ales posibilitatea de a evolua sănătos, de a câștiga, de a dezvolta. Cred că, până la urmă, relația foarte clară între calitatea și durata vieții se bazează pe aplicarea solidă care să ne permită să ne schimbăm stilul de viață. Și, în primul rând, referindu-ne la antibiotice, credem că cel mai important lucru să le folosim doar la recomandare medicală, doar după ce am fost examinați și niciodată apus și automedicație. Vă mulțumesc foarte mult și vă mulțumesc foarte, foarte mult.
Thank you. We saw the entire part of mapping all the needs in our sector and related with antimicrobial resistance. We continue with online. I suppose we have someone online. It is Mark Allen Windowson, sorry, head and pandemic treatments in AMR for World Health Organization. I don't know if it is able.
Can you hear me?
Yes. Thank you.
Great.
The floor is yours.
Great. Perhaps I think you're sharing my presentation. I'll wait for that to come up. And as it comes up, so yes, my name is Martin Willis and I lead the Pandemic Threats, Communicable Diseases and AMR at WHO European Office. And I'm sorry I couldn't be with you in person. As many of you know, WHO's in a restructuring process and things are busy here. Are my slides? Are you showing my slides or? No. Okay. In which case, one incident I misunderstood.
We saw you want to share with us, but after that you vanished.
Okay. Can you see my slides now?
It is a technical problem, but we solved it. Yes, we see it. It's
Great.
okay. Thank you.
Quickly, clearly, as is the topic of this, that antimicrobial resistance is not just about humans, focusing on humans at least, but it's also about the One Health, it's about equity, and it's about the environment as well. So very much a broad issue and needs to be tackled broadly. And just to reiterate, many of you will be familiar, but the global call to address antimicrobial resistance, the global action plan from 2011, showed the tremendous burden of almost 5 million annual deaths are linked with AMR. That's the number on the right, on the left rather. But also a lot of cost in productivity and in cultural losses, up to almost $1 trillion a year, with the perspective of a reduction in livestock productivity globally. So a huge, complex problem. And to tackle this, first in 2011, the European Strategic Plan on Antibiotic Resistance really focused on 4 main pillars of prevention to stop the need of antibiotics through WASH, infection control, and immunization, through increasing access to the correct antibiotics, diagnosis to make sure that the right antibiotics being used, and treatment to prevent, and stewardship to prevent excess antibiotics being used when they were not needed. And this is supported with data, AMR surveillance, and also research and innovation, strategic information, and then in turn supported by effective governance, awareness, and importantly education of physicians, and also of the population not to expect antibiotics for things that antibiotics are not needed. And from the beginning, WHO was very supportive of the One Health approach for national action, but it really has to start at the high level, as it were, at the global level, that WHO hosts a quadripartite secretariat for AMR, working with FAO, UNEP, and WOA. In countries, people already often apply the One Health approach because they are much, everyone is at the front line. There's fewer people working in country, and they usually work very collaboratively together. And often in the past, I think the problem was higher up, but there wasn't enough talking at the global level to support that on the ground interaction. But that's been to a large extent addressed now with the quadripartite for AMR. But there was a realization that for national action plans that there were problems in implementation of the specific challenges that countries were having, even though the prevention and the access was all fine, that countries needed a better roadmap to how to get there. And this then led to the AMR roadmap that will take us to 2030, which is a much more prescriptive approach to how to support countries in doing their national action plans for antimicrobial resistance. And these are some of the issues that comes up in AMR at the national level. Is the AMR narrative itself, the awareness of what AMR is and how it can be prevented. This comes back to community education, the lack of high-level leadership and buy-in, not enough governance structures. I explain why that's now beginning to be corrected. No budget. 70% of national AMR plans have no dedicated budget. And also just lack of implementation of high-impact interventions and policies, often because there's no feedback loop. The clinicians may send specimens for testing but don't have a timely or appropriate response, and therefore they lose motivation to send specimens. So improving that cycle has been a challenge, and a lack of qualified staff. So the implementation of the roadmap is now underway, and now, of course, what gets measured gets done, and you can see that there has been an increase in number of states that are submitting responses on how well they are doing with their action plans. You can see that it's been going up since 2017, up to a high in 2025, and this measures a country's advances in the multi-sectoral for human, agricultural, and animal, looking at governance, awareness, waste management, and a variety of other things. And you can see the sharp improvement. And you can also see here how the tracks data, this is the name of the system that monitors countries' action plans, can identify gaps and priorities to help target what a country will need help with. And you can see here the different colors representing the different advances or the capacities of different countries in the world. And you can see the subsection for Europe. But a lot of work still to be done. You can see from this graph that only just over half of countries, for instance, have AMR surveillance in place. And very lastly, AMR and innovation. We're now encouraging countries and encouraging research to look at other ways of tackling bacterial infections such as phages. And this is a project that we have just embarked on with WHO HQ. But a lot of more work is needed. Thank you very much for your attention.
Thank you. So, I have a question related with the initiative of One Health.
Yes.
It is an initiative at the European level, and we are Romanian. We are part of this initiative. How and when we see results from our strategies, because every year we have lost thousands of lives, and during this period I don't see any concrete results decreasing the number of deaths.
Sure. A number of deaths in which area in particular? In AMR? Hello?
Yes.
Sorry, just to understand the question better, you mean that there continues to be deaths associated with a lack of a One Health approach?
I ask if it's possible to formulate a point of view about the direct implication of the strategy in practical ways, and how we and when we see concrete results decreasing the number of deaths in Europe, for example.
Yeah. So I think that I don't have the data with me now on the number of deaths. You're right. I think taking a step back, I think what I've been presenting is measures of a process. How many countries have got plans? How many countries are doing things right? But what we need is what are the number of deaths directly linked to AMR, because that's what we want to stop. We don't necessarily just want to measure how many countries have plans. What we want to do is how many deaths are being prevented. And I think that's an extremely good question. I think it is happening. I think that clearly you would expect countries to have fewer deaths if they do some of these measures that we're putting in place. But nonetheless, it's very difficult to measure the number of deaths that we're saving, because it's quite difficult to understand if a death is due to AMR or not. Is it because the bacteria would have killed the person anyway? Or is it because there was not the right antibiotic in place? It's very difficult to actually make that judgment. And in my first slide, you noticed there were several categories of mortality. There was AMR associated and AMR linked. And this shows that it's difficult to actually get a handle and to know exactly how many people are dying of AMR. We can understand how many people are dying in an AMR, how many people have died because of with an antibiotic-resistant bacteria. But it's difficult to know if dying with antibiotic bacteria is because you died because of that antibiotic bacteria, if that makes sense, because of the antibiotic resistance.
Thank you. It is a point. So we go further. with inviting here in front Dr. Sabina Zorac and the Professor Traian Constantin, if it is. Yes? To stay with us. Yes, thank you. Thank you. So. You have mics. The floor is yours.
Oh, okay. So quite informal. First, I want to thank you for inviting me to speak in front of you. Can you hear me well? Okay, because the acoustic is not very good. Today I will try to present in 15 minutes, which is a challenge by itself, two models of automatic identification of Mycobacterium tuberculosis in histopathological and cytological slides. As you can see, it's quite a large team with different, almost completely different specialization, both doctors, epidemiologists, and machine learning engineer, and also we have a lot of contribution of Zai Artificial Intelligence, which is a startup. It was a startup, now is a little bit bigger, and it occurred by I'm sorry. We were some enthusiastic people trying to put a lot of technology in medicine, and as I will show you, histopathology is one of the last fields of medicine where AI is involved. So, I will take into consideration that most of you are not doctors, so I will try to show some pictures. What you see here, a long red bar, not quite long, is the Mycobacterium tuberculosis bacillus. As you can see, it's easy to miss. In fact, there are two bacilli there, and they were the only one in a section about 12 square millimeters. Imagine how difficult it is to find something like this, and 12 square millimeters means a piece of tissue of 3 per 4 millimeter, which is quite tiny. Usually in histopathology we are dealing with big chunks of tissue, about 2 or 3 centimeters per 2 centimeters, so I don't know, 6 square centimeters. So we have a problem. It's quite easy to miss, and we have to find a solution how to identify them. How can we answer this problem? We can perform more sections, perform more slides, and we have to use more time to examine the slides. More sections, how many? Technically in our department we determined that you need 4 sections in 4 slides, if it's possible, in order to find bacilli in paucibacillary lesions. More time to examine the slides. As my nephew is saying, really? More time? We don't have time, so the only solution is artificial intelligence. Why artificial intelligence would not use in pathology? Because it was not the moment yet. Now we have quite a lack of pathologists. As you can see, the optimum will be 100 pathologists per 1 million inhabitants, which is quite a lot. So in Romania, we will need 2,000. We are not 1,000, we are less. The current situation worldwide is about 30 pathologists per 1 million. In Germany, for instance, there are only 20 per 1 million inhabitants. Also, a lot of things are required from the pathologist. 20 or 30 years ago, the job of the pathologist, his task or her task, was to establish if it's cancer or not. Now we have to perform extensive sampling of the specimen. We have a lot of parameters to be reported, a lot of tests, immunohistochemical, molecular tests to be performed. Okay, so what have we done? We selected from more than 2,000 cases from our archive in Colentina University Hospital, about 570 cases. Most of them, 510, we use for training, the other for clinical testing. And we scan the slides. We obtain what's called whole slide images. They were annotated by 7 pathologists, and we end by having about 250,000 positive bounding boxes and more than 700 million negatives. We use several platforms for annotation. Why? Because annotation is awful. As you can see, we design a lot of rectangles, small, large, different shapes. We try to use another system with dots, just put dots, click on positive bacilli. It's easy, you can see the bacilli, the rod, the red rods. We also put red rectangles in areas without bacilli. Also this. Anyway, we ended with almost 250,000 positive bounding boxes. They were not enough. We applied extensive augmentation techniques, and in the end we had 2.5 million positive bounding boxes and a lot of negatives. I will not discuss too much about the deep learning model. It was a RegNet X4 architecture. We had a validation set consisting of 280,000 patches. And the results were quite nice. We had an area under the curve score about 0.968. Which is nice, as you can see in the green rectangle in the center with the positive score, the probability of having a bacilli there of 0.94. There is a bacilli, I'm sorry, I can use the pointer, but as you can look, there is a reddish, a pinkish something in the center. However, we had false positive results, so-called junk. Red blood cells were a really big problem. Look, you can see if a red blood cell is cut by the square, you end with a line, so it could be a bacilli. Also, the mast cells, also problems. You see here, the model considered that the granules dispose as a linear curve as a bacilli with a score quite big, about 0.96. We retrained the model, and the result of the area under the curve was bigger, 0.977. Quite good results, so we proceed to a clinical test, man versus machine, considering that from the 8 pathologists involved, 7 were women, is mostly a women against machine test. What was the procedure? The pathologist examined the slides, then we had a washout period of 2 weeks, and they examined the VSIs, the scans of the slides. It's a little bit different to examine a slide in normal conditions into a microscope against an electronic scan of the slide, and this can also may give false or positive results. And the results were compared with the Zaya algorithm. In fact, it was not Zaya by itself, but Zaya evaluated the results offered by Zaya, evaluated by a pathologist. Okay. We selected different types of cases. I don't want to enter into details, but for a pathologist, you can see that they were lesions somehow morphologically similar with tuberculosis. We don't want to give the humans.
Is possible to jump on the conclusion because we are pressed by time?
Oh, sorry, I knew that I have 15 minutes. Okay, it's not a problem. The results were quite good. On slide, the pathologist, the best pathologist performed as well as the model. And we compare our results with other researcher, and our results were very, very good. It's a good model for diagnostic. As you can see, later on, we try to improve the way the model presents the results, and the model can deliver a list of possibly bacilli. And if you want to see them on site, you can look and see in each square if they are bacilli. Also in paucibacillary lesions, you can see how nicely the bacilli are highlighted. And later on, we try to do the same thing on sputum in order to use our model as a screening device. It has good results both in lesions with a lot of bacilli and in paucibacillary lesions, as you can see. And our model gives very good results for a level of confidence over 90. The cases between 80 and 90 are suspected. Less than 80, there were no false negative cases. And, well, Zaya is trying to enhance the power of pathologists. I'm sorry.
Thank you. It is a great work. Yeah, remarkable. So, we're going forward with our next guest, Professor. The floor is yours.
Hello. My name is Traian Constantin. I'm the manager of the Teodor Burghele Clinical Hospital here in Bucharest, of course, Romania. Due to the fact that this panel is about infections and actually what they mean and how they affect the medical activity, I'll try to present in a few words a project that we had in our hospital. It is called Prevention and Management Improvement of Nosocomial Infection in Professor Dr. Teodor Burghele, which was based on European funds that we could access through the Ministry of Health. Just a moment. Okay. A few words about our hospital. We are maybe the largest urology clinical hospital in Romania. We have around 140 beds, 3 urology departments. We acquired last year the second level of accreditation, which is actually the highest in Romania, according to the National Authority of Quality Management in Health. Also, we are a member of the ROHEALTH-Cluster, the Health and Bioeconomic Cluster. And we perform in our hospital more than 5,000 interventions per year are performed. We have 2 operating units and in total 8 operating rooms. What is important to mention that more of 60% of our patients are not from Bucharest. Also, we have a cardiology department, internal medicine department, radiology and imaging departments, oncology, but only day care, and of course, a pathology department. These are a few data about our activity. Of course, during the pandemic, the number of admissions wasn't quite large, but it was significant. But as you can see, in 2024, the number of patients increased significantly. We have an important percentage of operated patients, with a very short hospitalization. And another thing that we succeed in performing, mainly probably of accessing that project, we managed to decrease the nosocomial infections. But here I should mention that also the patients with COVID infection acquired in a hospital, or for example, for those who are from medical field, we can have also infection with Clostridium difficile as a complication after an antibiotic treatment. But it is important that we succeed in keeping, let's say, a low rate of nosocomial infection. These are the few data about nosocomial infections. These are actually the number of patients that we found with this, but also, I don't know if I can use, this is a point, oh sorry. No, I wanted to see in the last column that we have a large number of patients with colonization, so patients which come to our hospital having a urinary infection, because mainly we are a urology hospital. A few words about our activity, a SWOT analysis. We have a very good team, and I consider a team with good professional. We have patients with very important complexity case. We treat patients with advanced oncological disease, advanced lithiasis, or other pathologies, but mainly we are, let's say, dead-end hospital, because most of the patients come to be solved in our hospital, and we do not have any other possibilities to send the patient in other part. About the weaknesses, we discussed mainly about the medical system weaknesses in Romania. Of course, in most situations are determined by the impossibility to have more personnel. The costs, and maybe it's not the place to discuss about the cost and how the reimbursement of the medical services are done. And another weak point from my point of view is that we have an old building. The building of the hospital has more 80 years old, but of course inside we try to respect the current standards. We have good opportunities, good collaboration, even with Cantacuzino Institute, and I thank you for it. And the threats are the problem regarding the increasing healthcare costs, having more complex devices means that the maintenance is also expensive, and we need to make a good decision, especially in directing the funds. About our project, this project consists in approximately 2 million in value. We had a chance to get 55 pieces of equipment which were used for disinfection, sterilization, air decontamination. I mentioned a complete endoscopy sterilization station for OR. And other devices that allowed us to better control the germ spread, and also to ensure a good safety for the patient. Also, before that project, we applied and succeeded in acquire other European funds for COVID pandemic, and also this allowed us to get good new medical equipment in the hospital as a CT scan. We succeeded in changing mainly the whole devices in the intensive care department, and also gave us the chance to be more, to get more courage in order to apply for European funds. What I want to do is to thank our partners, Frontier Management and Consulting company, which had a significant role in the management of our project, and I salute the staff at that company, Mrs. Duca and her colleagues, who actually gave us an important support in order to successfully finalize this project. Thank you very much. I'm a neurologist, not a manager. I'm also an associate professor in neurology, and my manager role, I hope that is just temporary. I'm kidding. But I was involved in the COVID project as project manager, and I learned a lot. I've learned a lot about how to deal with these opportunities. Thank you very much.
Thank you. Thank you. And also, I want to invite among us Professor Bogdan Tamba from University of Medicine and Pharmacy, Iași. Hello. So, I'm only one who has, the last one, who has something to say about this subject, and we pass the discussion to our professor. Okay, so we continue with my presentation to be able to conclude everything. Yeah.
So thank you all for joining. I'd like to raise up a little bit the excitement in this panel. I think all the people who joined this panel agreed the importance of the antimicrobial resistance especially in these days in Romania, and we're not very proud of, but we are all aware of it. So I think we should, on one hand, try to focus our presentations according to the instructions of the organizers to 7-8 minutes, but then at the same time leave the floor open for more questions from the online audience or the floor here. This is an open discussion, and we'd like to very much hear about your thoughts and ideas and challenges, or maybe questions or issues that you face in your own environments regarding this. But to conclude, we'll ask Professor Călin Munteanu to share his thoughts on the strategies in Romania for antimicrobial resistance. Thank you.
Okay, so I'm a researcher, but in the additional domain from the public health sector and antimicrobial resistance. I'm working in the field of medical informatics all the time. Also, I'm involved also with the public health sector because we need to collect data, and that's why I try to map some key statistics from 2021 because we need to figure out how and what large is our problem in this moment. And we know for facts we have 4,000 lives lost in every year, and also we have a problem with direct attributed antimicrobial resistance with 4,110 deaths, and also we have associated with other 16,000 or more, because it's not quite sure if it is from this cause or not, but higher impact on age from 70 plus, it is for sure, and we know for facts from the hospital, and the professor here he also get the similar data in our view. The Romanian national strategy about the antimicrobial resistance, we are officially involved to create a strategy, and we saw the steps according to 2006 and now, and the national health strategy for 2023-2030. We need legislation, we need support, and most important, it is to approach from multi-sectorial point of view, because not only the results from the hospital and also the death rate, it is important. It is important to have one health approach. That means we need to see also the veterinary aspects, also from the agriculture and also from the food industry, and also the health industry sector and environmental sector. With the veterinary sector, we saw a direct correlation between the increasing the antibiotic use and in animal in farms and increasing our antimicrobial resistance and also the cause of more deaths in every sector, from emergency room to every corner in specialty like urology or other. We have a problem. We have a problem, and we have a problem for 30 years in Romania. This problem is related with data collection system. We try to manage this situation in the strategy of digitalization, but it's not working yet, and we need results now to decrease our death rates from the antimicrobial resistance caused by many factors. And we saw some examples from our guests. Real-time analysis with predictive machines, it is possible to do. We saw it's possible to use AI to increase our productivity and increase our accuracy in diagnostics. And we need also this AI role in predictive analysis for entire healthcare sectors, especially for this kind of problem like antimicrobial resistance. And I simulate with, not with ChatGPT, with Llama model, an evolved model. What are the most important moments and how it's possible to influence the entire picture with an EHR system implemented in a function in Romania. We have here an example how it's possible to apply with the data and direct the strategy and the politics for this kind of problem. And also I saw the objectives for EU for health objectives, and I believe in 4 or 5 years from now, if we are capable to integrate more data as a public health sector, it's possible to see concrete results from our strategies, but our policies. It is very well done, but we missed the important part. We don't have data to predict how and when to have an intervention. Future direction and recommendation, we discussed this. Sorry, please. Peter, it is a friend of mine, and yeah, thank you. Yeah, we discussed this now in few moments. It is important for us to have a cross-sectional coordination and a real-time surveillance system. Data sharing, I repeat and I repeat again to understand better, it is the most and crucial fact to do in this moment for Romania. Leveraging with EU for health funding, yes, it is good, and with the support of ROHEALTH, I suppose we do these steps to get some money, some funds for developing some strategies, and also from this point of no return in Romania, targeting an educational program. It is important to have an educational program for entire sector. We need to restart the education in the sector, and we see also on the news what's happened in Iași. So, good news, it is possible to do it, but we need to collaborate, to work together. Yeah, I also want to thank you again, and I pass the microphone to my colleague, Professor.
Thank you very much. I think you really raised some difficult questions here and points, and I'd like to, yeah, please.
More or less primitive. I want to learn from you. What I didn't understand, you say, okay, we have the bacteria, they are now resistant against sulfamides or penicillin, yes. But what I didn't understand, please help me, I learned that the jump over of animal bacteria to human is more or less not possible, because they have another concept in the DNA. And out of your speech, I understand that the barrier between animal bacteria and human bacteria is that they are so similar that in your special case in Romania, you get really a problem. Is there no difference? Maybe I fail.
I don't know. Yeah, you have right. It is a difference between them, but we have a microbiota, and our microbiota is trained by our food. And our food, it is with great content of chemical additives, and also with antibiotics.
Okay, yeah, okay, this I understand. And now I come to the resolution for you. It is nice to make deep learning, but in your field, it is not the best. When you tried by machine learning, and here by the simple self-organizing nets or modules we speak together, then you don't need so many data. These special neural networks, they are as old as deep learning, but they need only 20, 40, 60 types of data, and then they start, because they are self-organizing, as they build out plugs. Yes? And when you take their special topology, and when you then use this principle computing by activities, you will find, even with small data sets, way fast resolutions. So, sorry, I cannot remember your name, Professor. Yes? I know the whole world is doing deep learning. For us, in the medical and in the military sector, it is nonsense. Because you need millions of data, and you don't have this data. And all the steps you have done, fantastic, congratulations. You rotated the pictures, you make them larger, you make them a little bit smaller. But unfortunately, I think, from our experience, and we have done it by diabetes patients many years ago, that it is overkill. If you use millions of data, the abstraction at the end of the training cycles may be in the right corner, but it may be also it is not in the right corner. So I would invite you as researchers that we share some results, how to do it with simple neural nets, with not so many data, and you will surely find out that you get clusters. And now I'm coming back. It would be very interesting for me if you take the animal bacteria resilience and the human bacteria resilience, put it in the same network, and then watch what will happen if the conditions are changing a little bit. Because out of our experience, yes, a good chance. We are just implemented in Horizon projects together with a Swedish university and German university. It is not about resilience, but it is about sepsis. And there we also try in pre-phases this new kind of neural nets, and you find a lot of literature, or I can prevent it. Okay, thank you very much. I don't want to have my own speech here.
Thank you too. I will try. Okay, so as I said, AI is very important, and it will always raise questions. However, I would like to go a little bit back to the basics. Germany or Netherlands had a very low incidence rate of in-hospital infections. Even 20 years ago, when there was very little or no AI or no computers, or 30 years ago. My personal impression is that it is more related to the standard of living. So we have 30% of the population in Romania with no access to clean running water and in-house toilets. So I would assume, yes, the people would consume more antibiotics in their homes, since they anyway run into more infections because they have no basic sanitary conditions. But how is that related to the in-hospital infections? What's your view? Maybe some people from outside Romania. How do you see this? Is it related? The community consumption of antibiotics, what do people take at home, to the in-hospital multi-drug resistant infections? And the second question would be for my esteemed colleague, Professor Stavaro, who represents the research area, and how do you think the Cantacuzino Institute and the Romanian researchers could help push forward and actually make a difference in the multi-drug resistance? It's not a pandemic, but it's still a very common issue in Romania. Thank you. So I will first leave to the floor, maybe there's opinions on this.
To the first question, the people who have already resistant bacteria in their organism, which may be opportunistic like Staphylococcus aureus, because you know that more than 50% in Romania have Staphylococcus aureus resistant to antibiotics. Yes, so these people would use unnecessary antibiotics, develop resistant pathogens, and then she go in the hospital and spread this kind of resistant, multi-drug resistant pathogens. Yes.
Yeah.
This is an hypothesis, and no, well, I have some statistic data.
It's good one and sustainable. Also, we need more data to know from social point of view. You see, the picture is very complex. You describe it. We have people who don't have access to clean water and toilet on the private and also in the public sector. And we have also the hospitals who has direct problem from this source. We don't have clean water in hospitals. We manage to view in the county 4 or 5 great hospitals, but the small one, we don't have enough funds to analyze all the sources of water on the county, on the country, because we need to understand how many points, weak points we have. We need to number how many in water, in public sector, in private sector, in antibiotics, in also food, because the food, it is a source of prebiotics, postbiotics, and macrobiotics, and we have a problem in this area, and also we increase our consumption of antibiotics during the meal from the diverse proportion of meat from diverse animals like chicken. Chicken are the most injected and has the enough quantity to have a direct effect in us, because during the preparation we destroy some parts of but we have also a part who has direct effect on us, and that's why we need more data about entire picture, and we don't collect the data from the hospital, because there I have many aspects about the patient, the direct relation with the social status, with all kind of things, and we need to understand to create this knowledge and spread the knowledge with education in the medical sectors.
Yeah, just one comment. I'm Anthony Pilanger. I'm a consultant in global health, and you know, AMR is a very complex problem with multiple aspects to be taken into consideration. But when we compare countries, you know, I'm living in Geneva in Switzerland. countries in Europe, in different regions of Europe, there's some easy gain that can be made. And we don't need data because we already know what has to be done. So of course, clean water is the basic, that's for sure. We know that it's extremely important, but there are other things. When you have AMR, it's not coming from one person from the countryside that goes once in a while at the hospital, right? It comes from the concentration of patients in the clinics, in the hospitals. And one way, some countries like France, and I'm French originally, have managed to reduce the risk of nosocomial infection is just to put one patient in one room. Let's avoid having 6 people into one big room with curtains. Bacteria don't care about curtains, right? And so there's a difference that is striking between the countries where you have 1 patient per room and countries where you put at least 2 per room. I lived in Canada. My wife gave birth in Canada, and she was with 3 other mothers into the same room with all the problems postpartum that you can imagine. We know that it's not the right way. So we have to easily segregate the patients into the room. We don't need to do that for the health workers. Why? Because the health workers are trained. They are the people that can protect themselves the best because they are professionals. But patients are not. So you can try to educate them on hygiene, on whatever. At the end of the day, they will never be better than a health worker. And the last thing is also investing a bit more into diagnostics. There are plenty of diagnostics for strep that exist. Very easily, you do that at the office in the doctor. And then you don't give antibiotics if it's a viral disease. Because we all know that there will be no effect. You just increase the consumption of antibiotics and you increase the risk of AMR. So I think just those little things, segregating people at the hospital, cleaning water, and testing with, diagnostic to be sure that it's a bacterial disease that require antibiotics, already you have a big chunk of AMR that will be prevented.
Thank you, and I think this really raises the ball for me, because I was looking at a 2021 Eurostat data. Basically, Romania consumes 10% less than France per capita in antibiotics overall. But at the same time, the AMR rate in hospitals in France is 5-6 times lower than Romania. So basically, you just answered what would have been my next question. How do, we consume as an average the same amount of antibiotics as a usual French guy, give or take, plus minus 10%. It's always like this in medicine. But the AMR rate is significantly lower in France. So I took note of investments in infrastructure, investment in hospital, investments in clean water, access to clean water, and the third one to this fast diagnostics. Thank you so much.
Nothing about new drug therapeutics and the importance of research on this area. Because without research and innovative new therapeutic drugs, we cannot solve the problem of MIR. So I think that
it's just a matter of time. It takes much more time during research, and we know that very well. One thing that is also important in the way antibiotics are used, we all know that we have maybe every 10 years a new antibiotic, and then we put all the patients under amoxicillin at the moment. And we know that resistance will come. At a certain point in time, we will have resistance, and we have more and more difficulty to develop new antibiotics. And I think we always try to put the healthcare cost at the lowest. thinking that it makes sense, economically speaking, because we are short-term thinking, but when you look at in the long run, it's absolutely not a great investment. Of course, getting 6 people into one room costs you less than 6 different individual rooms, you know? Same thing, when you give 1 antibiotic, it's cheaper than giving 3 antibiotics at the same time. But when you give 3 antibiotics, the probability of getting a resistant bacteria against the 3 will be much lower. So you increase a bit your cost, but you will have a long-term protection of your people. And so you will give enough time to Cantacuzino to come with new antibiotics.
Yeah.
But to our colleagues here in the clinics, what do you think you can do today with the resources that you have available today to decrease the rate of AMR in your sites? Because of course the easy answer is always, if we get more money, then we will get more things done. But let's assume today, what do you think could be applied today to lower this rate?
I think it's not money is not the problem, because if you need money, there are means to find them. I think that first of all, because most of our guests are from Western Europe, we should, and I think it would be a good idea to take the good knowledge, medical knowledge from them, because due to the history conditions, we were, let's say, we were in a step before the Western Europe, and I think a good idea is to implement the strategies that worked. And what you said about health condition in France could be applied here in Romania, but from a moment, let's say the governance should say that from this moment, the whole hospital system should be done like this. Another thing is that we should respect the medical protocols. Being a neurologist, we have the protocols from European Association of Urology, and in most urological intervention, antibiotic prevention is not recommended. So there are interventions when our colleagues in Western Europe do not recommend antibiotic, or only 1 dose. In Romania, things are a little bit different, and the problem is that the protocol is represented, or it is based on the personal experience of the doctor, and I think you can agree with me. And another good idea is to respect the medical protocols that should be applied to the same category of the patients. We do not discuss about complicated patients. We do not discuss about patients who visited many other hospitals. In my hospital, we have this situation that we have patients that already were admitted in other 2, 3, 4 hospitals, and also we get the idea to establishing the diagnosis as quickly as we can, because, for example, urinary lithiasis is mainly associated with urinary tract infection. You have a patient, if we have a patient that were instrumented in a hospital, just inserting a stent, and then that patient is sent to another hospital to be operated, there is a risk of infection. And of course, the idea is to ensure a medium level of medical health care in the whole country, starting with the small cities, not to increase and push an important pressure on the large hospitals in the main cities like Iași, Bucharest, Timișoara, etc. Because this is unfortunately the way that happened in our country. So I think so the money is not the main problem. I think the main problem is changing the way of seeing the things and starting from the base level.
Thank you.
Thank you.
Can I just make a comment on what Konstantin just said? I think one of the important aspects in the hospital, and you mentioned it, the doctor is the authority. But for example, in Switzerland, every 2 to 3 years, there's a review of whole the pharmacopée to look at the evidence of efficacy. And then there's new recommendations that are followed by all the doctors. That's at least a decision that is based on facts and data. And then you say, okay, if this antibiotic, for example, doesn't prove to be super helpful, then we stop its consumption in a given protocol. And in that way, you reduce the consumption of antibiotics. And the other way, which is coming more from North America, but I think in Romania you do it also, it's to, if you have a 10 days treatment with antibiotics, you just get the pills for 10 days. You don't get additional box of antibiotics that we all pile up at home, and we take it just because we are doctors ourselves, because that doesn't help neither. And I think that would reduce the cost of healthcare, that would reduce the risk of AMR in general.
Yeah. Thank you. It is, we are on between two worlds, the western part and the eastern part of the world. We based on your research, we do the decision, and it's not quite correct. We don't have enough data from our side to know the facts from Romania, not from France, Canada, or so on. Thank you. We are finished now, the session. Thank you for participating. Thank you, dear guests. Thank you for the guests on the internet. I pass the microphone. Yeah, it's done. Thank you.